This patient is a 47-year-old patient, gravida 2 P2 para 2 with breast cancer, who underwent a modified radical mastectomy in April 2013, followed by tamoxifen therapy. She developed amenorrhea and pelvic pain, which prompted an imaging study. On ultrasound, she had thickened endometrium and polyps. Hysteroscopy with polypectomy, along with sharp curettage, was performed in September 2013. The pathology was benign. A subsequent ultrasound demonstrated persistent thickened endometrium, for which she had an endometrial biopsy. The pathology was again negative for hyperplasia or cancer. A follow-up ultrasound in March 2014 showed thickened endometrium and cystic areas. Hysteroscopy was performed as shown in the video. There is partial occlusion of the upper fundus with only a small window for entry that can be probed with the MyoSure tissue removal device. Just above the internal os, there is evidence of thick scar tissue composed of bands and polypoid tissue, extending between the lateral side walls along the posterior surface of the lower uterine segment. The adhesion band is removed by applying the MyoSure device window to the tissue and moving in a lateral direction as shown in the video. The MyoSure tissue removal system is indicated for the removal of intrauterine tissue. The MyoSure XL device used in this procedure has a 96 mm window compared to a 54 mm window in the standard MyoSure device. The MyoSure device cutting window is kept in constant contact with the pathology being removed. This patient was treated with Cytotec 100 micrograms orally and 100 micrograms vaginally the morning of the procedure. No mechanical dilatation was used, since dilation may create false tracking into adhesions within the lower uterine segment or lead to leakage of fluid from the cervix if overdilation occurs. The window into the upper uterine cavity is used to help identify normal anatomy and extend the dissection laterally towards the side wall. Rather than cutting and separating adhesions as is typically done with the scissors, the MyoSure device is used to remove the band of scarring to normalize the uterine cavity. The Aqualex fluid control system was used for fluid management throughout the procedure. The intrauterine pressure was set at 80 mm mercury. Typically with adhesiolysis using cautery or scissors, I increase the intrauterine pressure to more than 100 mm mercury in order to put the scar tissue on tension to facilitate dissection. Lower uterine pressure settings may reduce the likelihood of fluid intravasation and fluid deficit. The upper uterine cavity is now entered. Intrauterine adhesions were first described in 1948 by Dr. Asherman. Damage to the basilar layer of the endometrium, such as with curettage, can lead to intrauterine adhesions. And cases of patients with adhesions with the uterine cavity have been reported in women undergoing treatment with tamoxifen. Surgical correction of intrauterine adhesion has been successfully completed hysteroscopically using scissors and electrocautery, resecting loops or tips. Complications can include uterine perforation and reformation of adhesions due to additional endometrial damage related to cautery effect. The goal of the hysteroscopic treatment of intrauterine adhesions is to dissect and remove the adhesions to restore the cavity to normal with minimal injury to the endometrial surface. By eliminating cautery and dissection into the myometrium using the MyoSure device, it is possible to reduce the likelihood of adhesions reforming post-procedure. Residual scar tissue and small polyps are removed from along the uterine sidewall and endocervical canal and sent to pathology from the MyoSure device tissue trap. The video showing the upper uterine cavity and both ostia appear normal. There are significant potential advantages of using the MyoSure XL for treating intrauterine adhesions. The procedure is done under direct hysteroscopic visualization, reducing the risk of uterine perforation associated with blind procedure. The scar tissue is removed rather than cut in order to return the cavity to normal appearance. Since the adhesions do not need to be placed on tension, less intrauterine pressure is required, resulting in potentially less fluid deficits from intravasation. With the MyoSure XL device, there is no damage to the endometrial surface from cautery or myometrial dissection, with potentially less risk of adhesion reformation. This is the first case report using the MyoSure intrauterine tissue removal system for the treatment of intrauterine adhesions. Thank you.